So now we will start with procedures for transglottic cancer. So supraglottic cancers that extends to the glottic regions and cause fixity of the vocal cord. These procedures are a combinations of vertical and horizontal partial laryngectomy, three-quarter laryngectomy, suprac required partial laryngectomy with cricohydropexy. So what is three-quarter laryngectomy? So combination of supraglottic horizontal partial laryngectomy and vertical hemilaryngectomy. Indications: glotto-supraglottic cancer spilling over the piriform fossa across the aryepiglottic fold. Contraindications: what is contraindication? Involvement of subglottis, involvement of cricoarytenoid joint, thyroid cartilage invasion, interarytenoid and post-required involvement. Resection resection body of the hired body of the hired thyroid cartilage supraglottic with pre-epiglottic space, true cone with paraglottic space and arytenoid if involved. Perform rarely today because of the high risk of complications as aspiration and technical difficulty in achieving a good closure.
So it is always important to keep in mind that first the patient should be fit for the surgery. Okay. Am I audible, Dr. Krishan?
Audible.
First thing that patient should be fit for the surgery is pulmonary function test should be normal. Whenever the patient is having any sort of smoking or any sort of addiction, this should be stopped. And the last thing is, whenever we are going for the conservative surgeries, it is important for us to see that many of the patients land up into aspiration after the surgeries because of some or the other things can land up into surgery. So if a patient is fit initially, then these complications will be less. Okay, Dr. Vish.
So coming to suprac required laryngectomy with cricohydropexy, what are indications? Anterior commissure involvement. Then there is impaired vocal cord mobility with mobile arytenoids. Early thyroid cartilage erosions with intact pericondyl. What are contraindications? Fixed hemilarynx with cricoarytenoid joint involvement. Subglottic extension more than 10 mm anteriorly and 5 mm posteriorly. Involvement of vallecula, base of the tongue, piriform, sinus, post required and inter-retroid regions. Then involvement of like this prior tracheostomy. Then poor pulmonary reserves. Resections include entire thyroid cartilage, paraglottic cartilage, pre-epiglottic space and epiglottis. Preserved cricoid cartilage, hyoid bone, and one arytenoid. So this shows the procedures that strap muscle divided away from the thyroid cartilage but not too close to the hyoid. Division of inferior constrictor at the posterior border of the thyroid cartilage lamina. The perichondrium incised in the same line. Then cricothyroid joint is gently dislocated, preserving the recurrent laryngeal nerve. The procedure is repeated on the other side. The isthmus of the thyroid gland is divided and the cervical portion of the trachea is predentarily to permit mobilization of the mediastinal trachea. Then initial entry is made into the larynx at the level of subglottis to the cricoid membrane. The periosteum of the thyroid bone is incised along the lower border and stripped off to encompass the entire preepiglottic space. After transvalvular entry, the epiglottis is scratched with the Alice forceps and delivered into the operative field. Mucosal cuts are made along the AE folds, preserving the arytenoids. The specimen is rotated outward from the less involved side.
One thing we should keep in mind in this slide, sorry, Dr. Krishan, I want to add one point that these are the mucosal folds which we have to preserve. These are the mucosal folds which we have to preserve for the post-operative voice reconstruction. Okay. Yes. So these should be kept in mind. Okay.
So the specimen is rotated outward from the less involved side to permit better visualization of the involved side. 3 sutures of 10 vicryl are taken as shown to prevent the to permit the pexy. Then the sutures is taken submucosally through the cut and around the head as shown in the this diagram. you can see this. This is very important post-operative complication of open partial laryngectomy. This is most commonly examined as in Viva. So 20% is the rate of overall complications local. What are the most common? So in exam, if they are asked, divide it. Okay, what are the local complication? What are the other complication related to swallowing and all? For example, in case if they ask the indication of, for example, they ask indication of any instruments or malab instrument is used in which surgery, you should divide it like that. Uh, General indication, then the in some specific surgeries like that. Uh,
Uh,
Local, what are the most common? Then wound infection, then dehiscence, then fistula, chylic, swallowing, dysphagia or strictures. What are airway related
you can
complications?
also add there is pharyngocutaneous fistula.
Yeah, they must have added in somewhere. No, they haven't added. Then we can add in the local, especially in the extended cases, extended uh,
Yeah.
supraglottic laryngectomy. Airway, aspiration pneumonia, laryngeal stenosis, laryngeal edema, granuloma formation, surgical emphysema, perichondritis, cricohydropexy breakdown. Systemic, we can
See,
add.
one should keep in mind whenever we are writing for the complications. Now, it is important that airway, see for the airway complications. Here, there is a pneumonia, laryngeal stenosis, edema, granulation formation. Means these are directly related to the lungs. Patient will not survive if his lungs get infected. So, it is very, very important for the patient to be pre-operative preparation part is very important when such cases comes. Okay. Yeah, Dr. Krishan, continue.
So recently, I had conducted one study on the preoperative score, means how better the patient are prepared to, and I have correlated with the number of days they are staying in the hospital. So along with that, the post-op pain score. So in that, it was concluded that if the patient are prepared, and I have actually means correlated with the scores, how well they are correlated, means if the patient is prepared properly, and how I had done that, I had given the pre-op preparation score. I had conducted this study last year, and I had presented it this year in the month of I think May June. I had presented, and that was one significant finding. And that study was actually the multi department study. We had included surgery, ENT, gynae, every. So coming to that, airway, we have surgical emphysema, perichondritis, cricoepiglotticopexy breakdown. Then systemic, we have cardiac, pulmonary, renal, infectious, and metabolic. So coming to the, I think this will be the last topic we are discussing. So transoral endoscopic laser resection performed with the suspensor laryngoscope and microscope coupled with CO2 laser manipulated with micro manipulator can be used for simple vaporization of the tissues in case of laryngeal papillomatosis, or to make fine sharp cuts in case of laryngeal stenosis, or for resection of benign or malignant lesion. Stretching tube, endotracheal tube wrapped in aluminum foil to prevent combustion of anesthetic gases, and sewed cotton balls to in larynx to prevent thermal damage. Goggles for OT personnel. These are the general laser care. So this is the photographic representation. So indications, when we do this transoral endoscopic laser resections in leukoplakia or erythroplakia of vocal cord, T1, T2 glottic cancers with freely mobile vocal cords, T1, T2 cancer of the supraglottis, select T3 supraglottic cancers with early invasion of the pre-epiglottic space with freely mobile vocal cords, T1, T2 cancer of the hypopharynx with this freely mobile vocal cords and with no invasion of the paraglottic or paraglottis or parapharynx, localized residual or recurrent cancers following the failure of radiation therapy for early cancer of the glottis, supraglottis or hypopharynx, non-squamous histology which is not radio sensitive, example neuroendocrine tumors, neuroectodermal tumors, minor salivary gland neoplasm. Advantages देखिए, resection complete in single sitting, day care procedures, tracheostomy not required, swallowing not disturbed, post-operative course smoother, can be offered to elderly or with compromised lung functions. Voice conservative options still available in case of recurrence. What are the limitation of this surgery? Inadequate exposure on suspension laryngoscopy, trismus due to OSMF, congenital anomaly or previous surgery or radiation, inability to extend leg, example cervical spondylosis. Then it's become difficult. Lesions on anterior commissure, anterior 1/3 of the vocal cord, infrahead epiglottis. Infrahead lesions on anterior commissure, anterior 1/3 of the vocal cord, infrahead epiglottis, vallecula, base of the tongue, which are difficult to visualize. This is classification of endoscopic excision. I think Dr. Shivani can discuss it.
Yeah, there are. Hello.
Yeah. Okay.
Type 1 is the European Triangular Society, that is 2000. The tissue removed whenever there is an endoscopic. We see these are also the conservative surgeries. Classification of endoscopic resection include type 1, 2, 3, 4, 5, A, B, 5, C, D, and 6. Okay. So go see for the first, that is a subepithelial chordectomy. Subepithelial chordectomy, we used to remove only the epithelium over the cords. And in the subligamental, we used to remove the epithelium, Rinke space, and the vocal ligament. For this, you have to be very thorough with the what are the sides of the vocal cord, and what are the various structures of the vocal cord. Okay. In third, in the transmural, we used to remove the epithelium, Rinke space, vocal ligaments, and the part of the vocalis muscle. In fourth, in the total chordectomy, we used to remove extend from vocal process up to the anterior commissure, and up to and with or without the inner perichondrium. Okay, it is very important to preserve this also for the laryngeal for the voice preservation. And fifth is the extended chordectomy. 5A is the contralateral vocal cord. If there is an involvement, then the total chordectomy with anterior portion, contralateral vocal cord, and the Boyle's ligament. These are very important. Whoever is listening this descriptions, I would like to suggest him that whenever you are going for any of the surgeries, you should be thorough with the anatomy. And this is Boyle's ligament with or without the parts of the. Okay. And then fifth B is the involvement of arytenoid. Then total chordectomy, arytenoid cartilage partially or totally removed, and preservation of the posterior arytenoid mucosa. Here also it comes the posterior posterolateral or posterior arytenoid mucosa, and this mucosa is very important for the preservation of the functions of larynx. Then involvement of the ventricular fold, we used to remove the means like total chordectomy, Morgagni's ventricle, and the ventricular fold. For the subglottis, we do the total chordectomy, subglottic tissue up to maximum 1 centimeter below the glottis. An anterior commissure proposed in 2009, in which there is anterior commissure with anterior part of the vocal cord without the infiltration of the thyroid cartilage. Okay.
Yeah.
For the European
that was for glottis. This is for supraglottis.
Supraglottis. The tissue removed in the supraglottis are limited excision of the small size superficial lesion of the free edges of the epiglottis, the array epiglottic fold, the arytenoid and the ventricular fold, and any other part of the supraglottis. In B, in type 2, we used to remove the medial supraglottic laryngotomy without the pre-epiglottic space. These are very important. See, every part we should be knowing the anatomy first. So we will be like cleanly observe and cleanly imagine which parts are removed. In the 2A, it is like superior hemi-epiglottomy, and 2B is the total epiglottomy. And 3, we used to remove the medial supraglottic laryngectomy with the pre-epiglottic space. 3A is without ventricular fold, and 3B is with ventricular fold. 4 is the lateral supraglottic laryngectomy, which may include the ventricular fold and the arytenoid. That is 4A and 4B.
Yeah.
These are the diagrams. Here we can see in the first subepithelial resection, that is type 1 chordectomy, in which mucosal incision is made with a CO2 laser. Keep in mind that whenever these are the conservative surgeries, so we will use a CO2 laser around a hyperplastic or dysplastic lesion. These are the pre-malignant lesions which are used to remove with the help of a laser. And subepithelial resection in progressing preserving the vocal ligaments. It is very important whenever you are doing a stripping like lesions, removal of the superficial part of the vocal cord. It is very important to not to touch the ligament, not to touch the ligament, vocal ligament, because it can lead to the hoarseness of voice. Okay, this is very important to note. Okay, and the second diagram is showing how these parts are removed. That is anatomical specimen, which is non-fixed, and the dotted line shows the plane of resection of the supraglottis. Okay, these are the plane of resection. See how the epiglottis is nicely seen. It is as a leaf shape, and these are the two cords. Okay. Okay. With this, I would like to tell all the PGs, whoever is seeing this presentation, that whenever you are going for a patient of examination of larynx, firstly, the 2-3 things are very important. Like first is the indirect laryngoscopy. Indirect laryngoscopy procedure तुम्हें हमेशा पूछेंगे in the PG exams. Okay, PG viva में हमेशा पूछेंगे what are the structures of the larynx and what are the structures which are seen in the indirect laryngoscopy. What are the hidden areas of the larynx what are the hidden areas of the larynx जो 6 है वो तुम्हें पता होने चाहिए. What is the staging of larynx? This is very important. Okay.
diagram which
larynx
people make in exam ना, उसमें साइड रिवर्सल और इसमें कंफ्यूजन नहीं होना है. तो डायग्राम में आपको डायग्राम बेसिकली अगर आपका लैरिंग्स का केस है, सीए लैरिंग्स का, तो एक्सटर्नल विल सी द डायग्राम. सो डायग्राम आप अच्छे से बनाओ. और अगर आपको कभी भी डाउट हो एग्जाम में तो जरूर आपके सीनियर रेजिडेंट जो भी होता है उनसे एक बार कंफर्म कर लो एक बार डायग्राम. क्योंकि कई बार क्या होता है एग्जाम स्ट्रेस में आप साइड रिवर्स कर दोगे, या फिर कुछ लोग को लगता है एंटेरो पोस्टीरियर रिवर्सिंग कर देंगे, वो राइट लेफ्ट की रिवर्सल होती है, एंटेरो पोस्टीरियर की रिवर्सल, इसमें दे गेट कंफ्यूज. सो और इसके अलावा
you have to practice thoroughly the position of vocal cord, how it is like midline position, paramedian position, with various diagrams, supraglottis, glottis, subglottis. Also, whenever it comes to the second slide which we have already shown, in which we have already discussed the what is the importance of the cricoid and the arytenoid unit. Cricoid and the arytenoid unit is very important to be, it should be preserved in every laryngeal surgeries. And if it is T3, it is up to T3 lesion where the vocal cords are not fixed. It is very important for all the residents to note that these conservative surgeries play a very, very important role as this will lead to the conservation of the voice of a patient, even if it is not as good as previous one, but it will definitely help the patient to have some voice so can he will not be handicapped for the rest of his life. Okay.
So these things are important along with जब आप रेजिडेंसी में जाते हो और जब आप 70 डिग्री ओपीडी में करते हो, तो जब आपने डाला इसको पेशेंट उतना अलाउ नहीं करेगा, लेकिन आप वहां पे बीइंग अ रेजिडेंट आप सीखने के लिए भी हो, तो आप एक बार सारे स्ट्रक्चर एक बार अपना एंडोस्कोप घुमा के देख लो कि कहाँ पायरिफॉर्म फोसा है, क्या वेंट्रिकल है, क्या. अगर आपको कभी भी डाउट लगता है तो आप होता क्या था नॉर्मली हम लोग जब पेशेंट का ओपीडी में करते थे तो एक बार 70 डिग्री का फोटो फोन में रहता था, देख लेते थे अच्छा ऐसा स्ट्रक्चर. नाउ आई विल कोरिलेट. जब हमने 70 डिग्री करना शुरू किया था अपनी रेजिडेंसी में, सो हम कोरिलेट करते थे, तब आपको याद रहेगा और तब मतलब आपको रियली एक 3D इमेजिनेशन होगा और आपसे गलती होने के चांसेस कम होंगे एग्जाम में या राउंड्स पे या वाइवा में. So this is one thing. बाकी CA larynx का we'll do one case presentation also, और in coming month मतलब this month of August we'll discuss theoretical topics one by one. अगर आपको लगता है कि कुछ और टॉपिक डिस्कस करनी चाहिए, you can WhatsApp me. My WhatsApp number will be in this description section of the video. We will try to discuss more of the ear, nose, throat topics. So I think we'll try to do every alternate day कि मतलब वीक में 3-4 डिस्कशंस हो जाए 40-50 मिनट्स के अच्छे एनरिचिंग डिस्कशंस. So I think we can wind up